a rising star at the DRI. Oh, I should mention we're recording. I got my window popped up, so this is being recorded. But anyway, Dr. Abdulreda, he's a rising star at the DRI. He is a National Health Institute funded fellow through the prestigious National Research Service Award. And he initially joined the Cell Biology and Signal Transduction Lab, where the living window model was developed to study islet biology in the living animal. Since then, Dr. Abdulreda has developed the living window model to study immune responses during diabetes development or rejection of transplanted pancreatic islets. In addition, Dr. Abdulreda, in collaboration with other scientists at the DRI and the Bascom-Palmer Eye Institute, is exploring islet transplantation in the anterior chamber of the eye as a potential clinical transplantation site in the treatment of type 1 diabetes. And this FDA-approved phase 1 clinical trial will test this approach in a very select group of type 1 diabetes patients. And it's amazing research. And so I'm very excited and pleased to have our presenter for the evening, Dr. Midhat Abdulreda, join us. Thank you so much.
Thank you very much, Brandon, for the kind introduction, and thank you all for taking the time to share this evening with us. As Brandon said, my research has been focused on a few areas at the DRI, primarily with a focus on the immunology of diabetes. My research really, while focused on type 1 diabetes, is highly applicable to type 2 diabetes as well. So if you would allow me, I would like to share a few slides just to have some visual aid to what I'm going to be sharing with you today about my research program at the DRI. And at the same time, hopefully that will elicit some questions that I'm looking forward to answering. Amy, I should be able to share, right? Or Sarah, right? Can you see my screen?
Yes, you shouldn't have a problem sharing.
Okay, great. Thank you. So as I said, we're going to be talking diabetes today. I'm sure all of you are familiar with diabetes and the tremendous burden it places on individuals, families, communities, and society in general, as well as economies. Again, you're well aware that there are two types of diabetes, type 1 and type 2 diabetes. The more prevalent type is type 2 and commonly referred to as non-insulin dependent diabetes, although in advanced stages, type 2 patients would require insulin administration. I'm not going to get in type 1 diabetes, which is called insulin dependent diabetes, where insulin must be administered to replace the lost insulin for survival. I'm not going to get into the reasons as why diabetes develop. This is a very complex area, particularly which type we're talking about. I'm going to focus more on an area that we have been actively involved in, which is a form of therapy for type 1 diabetes, which is also applicable to type 2 patients with insulin dependency. So again, as Brandon mentioned in the introduction, I have the privilege to be at the helm of a first-of-a-kind clinical trial evaluating the general safety and potential efficacy of pancreatic islet transplantation in the anterior chamber of the eye. Again, this is an FDA-approved trial that is being conducted in collaboration between the DRI and the Bascom-Palmer Eye Institute. Of course, this is a team effort that cannot be possible without the close collaboration I have with DRI colleagues clinician scientists, as well as colleagues from the Bascom Palmer Eye Institute. So the trial, as I mentioned, is FDA approved. I will focus basically my few slides today on the clinical trial, and I will show you a little bit about, the background, research behind it, and why we think this is a very promising approach to treating diabetes, both type of insulin-dependent diabetes, type 1 and type 2. So the trial, as I mentioned, is FDA approved and is listed on clinicaltrials.gov. Effectively, if you want to look it up, you can go to clinicaltrials.gov and search by the identifier ID you see there, or if you simply Google my name with clinical trial, Abdulreda clinical trial, you will get an immediate hit on it. That takes you directly to the clinicaltrials.gov webpage, where more details on the research and the inclusion-exclusion criteria, even contact information for myself and for other clinical team members is available there. Basically, in a nutshell, who qualifies for this trial? It is, in fact, everybody who is between the ages of 18 and 70 years of age, male or female, who has type 1 diabetes and has been diagnosed as legally blind, at least in one eye. Clearly, this is a very innovative and new work that has not been done in human subjects before. That's why we opted for the conservative approach initially to evaluate this in legally blind patients. But we hope and we think that this will be safe to be expanded to other seeing patients, and hopefully that will become more clear in the coming slides. So why islet transplant? As we know, in type 2 diabetes, for example, there are many treatment options that span lifestyle changes, exercise, diet, to pharmaceuticals, drugs that can be taken, even surgical interventions like bariatric surgery that can have a significant impact on type 2 diabetes and improving the lives of type 2 patients. But in type 1 diabetes, unfortunately, the treatment options are limited. So I said I'm not going to get into the reasons as to why diabetes occurs, but just briefly to put this in context, we know that type 1 diabetes is a life-altering disease with serious complications if blood sugar is not controlled. We know that it is caused by a process referred to as autoimmunity. It's basically when the immune system of the person, him or herself, turns on the insulin-producing cells in the pancreatic islets and of the pancreas. And type 1 diabetes manifests in ultimately and is clinically diagnosed when destruction of these insulin-producing cells occurs beyond the 90% of them in the pancreas, at which point the patient loses control of the blood sugar level, where it increases, also referred to as hyperglycemia, and at which point clinical diagnosis is rendered. As I mentioned, the treatment options are rather plentiful in type 2, but are really limited to insulin replacement in type 1 diabetes. And insulin replacement can come in two forms, either by daily injections with a syringe or by biological replacement, based essentially through the transplantation of the cells that produce insulin. And biological replacement comes again in two flavors, either by transplanting the whole pancreas, which is illustrated in this cartoon here. Basically, it is considered a major surgery, highly invasive, and unfortunately has a high rate of complications post-surgery. And the other form of biological replacement is the transplant of isolated pancreatic islets. So effectively, instead of transplanting the whole organ, which is composed, more than 90% of it is composed, in fact, more than 95 or 98% of it is composed of what we call exocrine tissue, basically a type of tissue and cells that have nothing to do with blood sugar control, more so with digestion. We isolate the pancreatic islets that are specifically responsible for producing insulin, controlling normal blood sugar levels, called again the pancreatic islets. We transplant those islets themselves instead of the whole organ. Because the islets are not as big as a whole pancreas organ, the procedure is really minimally invasive to implant those pancreatic islets, and the rate of complications in general is significantly lower in islet transplant versus whole pancreas. This is a scheme that basically illustrates the procedure of pancreatic islet transplant. We also use the term or acronym TX for transplant, if you see it on the following slides. Basically, a pancreas is obtained from a deceased organ donor, and the islets again are isolated from the whole pancreas into these individual isolated islets, which you see. Again, the collection of the islets is also referred to as the endocrine pancreas, which is again what controls blood sugar levels. And these pancreatic islets, endocrine pancreas, constitute again no more than 2% of the whole organ. So effectively, the pancreas is processed in a way to isolate the islets. Dr. Ricordi, our former scientific director of the DRI, is the inventor of the Ricordi chamber, which is used worldwide to isolate islets nowadays. And basically, these isolated islets are infused into the venous system of the liver of a diabetic recipient. So currently, we transplant pancreatic islets into the liver. And we know from almost 3 decades of transplanting islets into the liver that pancreatic islet transplantation has many benefits, primarily in improving the glycemic control of diabetic patients, which consequently results in the prevention of severe hypoglycemia and other diabetic complications, such as heart disease, neuropathies, and retinopathies, and other complications associated with diabetes, if not controlled properly. And all these benefits result in significant improvement in the patient's quality of life. Again, it's a relatively minimally invasive procedure with significantly lower risk of complications compared to the pancreas. But just like with any other therapy, there are challenges. And most of these challenges appear to be related to the liver as a transplant site. So some of these challenges is a phenomenon referred to as instant blood-mediated inflammatory reaction, abbreviated as IBMIR, which is basically, as the name says, it's an inflammatory reaction where the implanted islets, the transplanted islets are impacted, which lowers basically the efficacy of the transplant. Again, this is a liver-specific type phenomenon. And because of this, typically, there's a need for multiple infusions to achieve insulin independence in the recipient. And this imposes, unfortunately, additional challenge because of the limited availability of cadaveric organ donors, and particularly pancreas. And in some cases, although infrequent, there might be some bleeding from the liver during the infusion, but there are technical ways to prevent this by injecting certain foams, which are commonly used in surgery to minimize this. And because the islets basically end up in the liver, in the venous system of the liver, they are difficult to monitor directly to see what's happening with the graft. So that's more of a practical limitation in monitoring the graft. And because of these challenges together, particularly again related to the liver as a transplant site, the general clinical experience so far indicates that on average, islet grafts can last with very good function for up to 7 years, although there are examples of patients who have been going on more than 15 years without the need for insulin administration. So this is rather of an average estimate. But again, because of these challenges, which I already mentioned, are specifically related to the liver as a transplant site, there is an active search for new sites where we can transplant islets to avoid these liver-specific limitations. Many research teams in the nation and around the world are exploring various sites for islet transplant, including at the DRI. You may have heard of the trial that was evaluating the omentum or the mental pouch as one of those new sites. Other people are exploring the subcutaneous site, inguinal area, and intramuscular. We have set our eyes, no pun intended, on the eye. I'll show you in the next few slides how that's done and why we think the eye is a promising site for pancreatic islet transplant to treat diabetes, insulin-dependent diabetes type 1 and type 2. And to be more specific, we transplant the islets in the anterior chamber of the eye, which is effectively the space right behind the transparent cornea and in front of the colored part of the eye, also known as the iris. So effectively, we isolate the islets from a donor, and then we infuse them through a tiny incision through the cornea. There's no bleeding because the cornea has no blood vessels, and basically the islets are deposited on top of the iris as illustrated in these red lines. And the question is, why the eye? Well, the eye has a lot of unique advantages I'll enumerate in a second. But obviously, by now, I think I have established that there is an existing clinical need for new transplant sites where islets can thrive without the complications encountered specifically in the liver. So, as I mentioned, transplanting islets in the eye, specifically in the anterior chamber of the eye, has unique advantages. These are some of these advantages. Again, it's a very minimally invasive procedure. There's not even a bleeding, simply because the small incision in the cornea, which is commonly done by ophthalmologists for various procedures when we undergo cataract surgery or any type of eye surgery. Ophthalmologists make these incisions in the cornea routinely, which heals pretty well. There is no IBMIR. This phenomenon does not occur. It occurs only in the liver. And because the eye is exposed effectively, particularly the anterior chamber of the eye is exposed to the outside world where there's plenty of oxygen in the ambient air, there is very high levels of oxygen in the anterior chamber, which is conducive to the pancreatic islet, especially during the initial period after the transplant, which is a very critical time period in any transplant site that is not the eye, where in a matter of 2 weeks or so, the islets can be really under very low oxygen levels, which can be detrimental to their survival and the long-term benefits of the transplant. This does not occur in the eye. And because we have the only transparent, 100% fully transparent tissue in the body, which is the cornea, through which we can look at the eyelids inside the anterior chamber, we can, in fact, monitor non-invasively the eyelid graft. And this allows us to detect any potential immune reactivity or rejection of the graft, so we can intervene in a timely fashion when needed. And another great advantage of transplanting eyelids in the eye is having direct access to the eyelid graft microenvironment, and this can be utilized for diagnostic and prognostic purposes. Again, ophthalmologists routinely sample the aqueous humor, which is the liquid that bathes the anterior chamber of the eye, which is, when we put eyelids there, also would be bathing the pancreatic islets. So any product the islets are producing is represented in that solution, in that liquid, which we can take a small sample of and basically understand what's happening with the islets and react accordingly. Another great advantage is the unique opportunity to administer drugs, either anti-inflammatories or even immunosuppression via eye drops topically. So there's no need for systemic immunosuppression, which is required in all transplantations. And many of us know that immunosuppression comes with very serious and severe side effects. So, and one other great advantage of the eye is what's known as immune privilege. And immune privilege effectively means that the immune system is dampened, is weakened inside the eye for reasons we don't understand, likely evolutionary reasons. But this immune privilege can actually promote the survival of the graft and minimize the chance of immune reactivity and rejection, to the point where immunosuppression may not be needed at all altogether, or if needed, it will be needed in significantly less doses and concentrations. Again, a great benefit in a transplant application without the need for continuous immunosuppression. And I'll show you a slide on this a little bit more later. I'm going to pause here for a second and ask you that if you have any questions so far at this point, please feel free to interrupt me, and I'll be more than happy to answer them.
I have a question.
Sure.
It seems a very small area to put the islet cells in. I mean, I think the whole concept is obviously fascinating, but it seems like a really small area. I mean, will you get enough islet cells in there? And I'm assuming you figured out that they can work from that area to release insulin into the body. And lastly, it doesn't do anything to harm, let's say it was a normal eye. Those are my questions.
Excellent questions. Excellent questions. And if you would allow me, I would like to answer them in the next slides.
Sure.
And if I don't, please, by all means, interrupt me, and I'll be more than happy to revisit what the slides may have not answered. Is that good?
Yes, please. Thank you.
Great. Thank you. So those are excellent questions, and that's exactly what I plan to cover in the next few slides. So the obvious question is, can this innovative approach be applied in a clinical application? And to answer that question, we obviously have done this in smaller animal studies, but the next best thing to humans to demonstrate proof of concept would be monkeys, non-human primates. And what you see here is are basically time-lapse images of the transplant procedure in a monkey eye. And effectively, as I said, it's a relatively simple procedure, and minimally invasive. This is a knife that ophthalmologists use in ocular surgery. Tiny incision is made. As you can see, the cornea is fully transparent. All we see is the iris and the pupil underneath it. But here, when the knife contacts it, you can see a little indentation in it. Basically, we make 2 tiny incisions, and then we introduce the eyelets through a blunt needle that's called a cannula, and the isolated eyelets are deposited through the cannula throughout the surface of the iris. And we place an air bubble over the pupil to basically isolate it so eyelets don't slip in underneath and behind the iris. So this is an image of that monkey eye you just saw. At the completion of the procedure, you can see the 2 incisions here, barely visible. Again, no bleeding whatsoever. The air bubble remains there, which typically dissipates overnight naturally. And what you see really here are pancreatic islets. And this is an example of a monkey eye that had been transplanted with islets, a little less islets. And this is what we call an angiography study, basically, where we inject a fluorescent dye called fluorescein that fluoresces and lights up in green when we shine a blue light on it. And this is a short video, basically looping, where you can see the eye of this animal before injecting IV the fluorescein, and within seconds after injecting it. And you can see that all these islets that are scattered throughout the iris are lighting up with this fluorescein dye, simply because they are engorged with blood vessels. And this fluorescein, when injected IV, diffuses throughout the body, and it lights up wherever blood vessels exist. So this is a direct demonstration of these islets being engrafted, as we call the process, when they basically stick and become vascularized. So they are being supplied with blood, so they get enough oxygen and nutrients, but more importantly, they're sensing blood sugar level in the blood and reacting accordingly by producing and releasing insulin. So a part of the question you asked, I think, was answered here, but I'll continue in answering it and the other ones. So obviously, this was proof of concept that this is doable in the non-human primates as a prelude for clinical studies. And of course, these are the types of studies that we gathered and we went to FDA with, so they allowed us to and approved the clinical trial. But the next question is, which was asked, is it safe? So how do we assess safety of this procedure? Obviously, we cannot say whether it's safe or not in humans until we have done it in humans. And this is exactly what the clinical trial was designed for. Again, as I mentioned, it was designed to assess the general safety of this procedure and the potential efficacy. But the best next thing, again, are experiments in the non-human primates. And one of the things we can look at is the intraocular pressure, also known as IOP. In 4 monkeys we have transplanted, and we can look at the IOP, the difference in the intraocular pressure between the right eye and the left eye. And in this case, the eyelets were transplanted only in the right eye. So as you can imagine, if the transplant in the right eye is causing the IOP to go up, the difference between the right eye and the left eye is going to go up. It's going to be positive. And typically, we all have fairly equal IOP in both left and right eyes, as do monkeys. So technically, if there is no change, the difference is going to be very close to 0. And if there is a difference in an increase, it will be above 0. If there is a decrease, it will be below 0. And as you can see, in all 4 of these animals, the IOP basically seems to oscillate in a very random way. Again, indicating that there is no increase in the IOP, which is a very important measure of safety. You and I, when we go to the ophthalmologist once a year, or how often we go, typically they do measure our IOP because it's a very direct measure of how good our eyes are. And again, by this measure, there is no impact on the eyelid transplant in the eye. Another measure is to look at the visual acuity. Again, I'm not gonna bore you with these graphs, but what they effectively measure is the visual ability, acuity, and the visual acuity. And effectively, as you can see, this animal was transplanted with eyelets in both eyes, and its vision was basically 20/20 in both eyes. Again, this is a direct measure that vision is not impacted in an animal that is very close to us. But in mice, we also, with the help of colleagues from the Bascom Palmer Eye Institute, we were able to also assess visual acuity in mice transplanted with eyelets in their eyes. And this is how this is done. Basically, the test relies on the involuntary nystagmus response of the eye, which is we humans also have. Nystagmus reflex response is basically when the eye tends to oscillate back and forth when we stare at, let's say, a train passing by in front of us, and we're trying to catch every car that passes. Our basically eye involuntarily develops a reflex referred to as a nystagmus response, where it will oscillate back and forth. In mice, when this occurs, also the mouse has a distinctive behavior. Well, the head also rotates, and you're gonna see in this video where the mouse is positioned in this device, where these black and white bars are rotating. We can change the direction of the rotation from right to left and from left to right, or vice versa. And you notice how the mouse is freezing when it takes notice of these bars, and then it develops that nystagmus response, meaning the mouse is able to visualize, is able to see these bars. And we keep doing this effectively while shrinking the width, the size of these black and white bars, and effectively to the point where the animal loses the ability to see, to resolve, to distinguish between the white and the black bars, and that determines its visual acuity. So it's a test actually that's very clever. This is what's used with in human infants when we assess human infants' visual acuity, so we can prescribe the correct glasses for them, prescription glasses. So in doing this test, we measured the visual acuity in black mice, also called B6 mice, that were transplanted, and in other black mice that were not transplanted. And we see there is no difference between the transplanted animals versus the non-transplanted ones. And when we did this test in albino mice called RAG --, mice, which are known to have compromised vision because of the albinism, we see a significant difference, confirming that, first of all, the test is working, but also that there is no difference in the black mice when we transplanted them. More importantly, when we perform this test in the same mice that are transplanted in the right eye, and the left eye is left untouched, we also see no difference between the visual acuity between the right and the left eye of the same animals. So again, this is a direct demonstration in another mammal that transplanting eyelets in the anterior chamber of the eye does not impact vision. The next question and pertinent question is, does it work? Which goes to your question about the size and the space available in the anterior chamber of the eye. So in mouse, when we transplant enough of these islets in their eyes, we can cure them from diabetes. What you're looking at here is the blood sugar levels in many mice that were diabetic. You can see their blood sugar levels is very high. And when we transplant them on day 0, we almost immediately cured their diabetes, and they remain cured for almost a year and a half. Again, in a mouse lifetime, this is significant. And when we look at the mean or the average of the blood sugar level in all these mice, and we can see that they're maintaining normal blood sugar level despite the fact that they're almost doubling in size during this extended period. So this is direct indication that the eye can accommodate enough islets to impact significantly on diabetes and in correcting hyperglycemia. Again, going back to the monkey, we did the same thing in the monkey, which again, you probably guessed that from the previous slides. And here we're looking at a diabetic animal, monkey, that required insulin on a daily basis. And this is its daily insulin dose here on the left. And what you can see that before transplant, before this day 0, the animal needed some slightly higher levels of insulin on a daily basis. And after transplantation, this was reduced noticeably. What was also improved is these high and lows, the extremes of the high and lows were also reduced, indicative of glycemic improvement. But more importantly, when we look at the A1C on this axis, we see that about a year after the transplant, the animal A1C returned back to normal levels. And again, this is a diabetic monkey that was made diabetic, so we know its levels before it was made diabetic, and this level was comparable to where it was before inducing diabetes in it. So again, this is another indication in the monkey that implanting islets in the eye can be effective. Another way to look at this is when we look at the insulin, daily insulin requirement, we see that the frequency of doses of certain high dose was reduced substantially after the transplant. The green line basically represents the mean or the median of the daily insulin dose after the transplant in comparison to pre-transplant. And although the animal here still needed some insulin, albeit lower than what it did before the transplant, there was a significant improvement in its fasting blood glucose levels as well as fed blood glucose levels. And this improvement was obviously, significant improvement rather, was observed after the transplant, post the transplant. Again, direct evidence demonstrating that the animal was experiencing significant improvement in glycemic control. I did mention in the beginning that intraocular islet transplant has the significant advantage of immune tolerance. By harnessing the immune privilege of the anterior chamber of the eye, immune tolerance, basically the recipient's immune system can be made tolerant towards the transplanted islets, which would otherwise be rejected if no immunosuppression is given. What I'm going to show you now is basically work that we published not too long ago, where we demonstrated in both mice and monkeys the induction of pancreatic islet transplant tolerance. So in mouse, we give this immunosuppressant called anti-CD154 only for 7 days, 5 doses up to 7 days after the transplant, and then we stop it. And you can see that these islets were thriving up to a year after the transplant without any immunosuppression. This is basically what we call the survival curve, again, where the treatment is given for a very short period, represented by that gray bar. And animals treated transiently with this drug, the anti-CD 154-40L, basically demonstrate a higher percent of no rejection in comparison to the other conditions. And this is also represented, the case rather, when we challenge these animals with another transplant. The same data were reproduced in monkey as well, where we give the immunosuppression for a certain period of time, in this case, 248 days. And for almost 2 years after the transplant, without any immunosuppression, the islets survived and were intact. By now, we have demonstrated this in several monkeys, including 2 species. One is called the baboon and the other called the cynomolgus. And again, you can see here the survival of the pancreatic islets in the eye without any immunosuppression after stopping the immunosuppression in all these 3 animals, which is the time period from the dotted line up to the red or green, red, or blue dot. So again, this is direct evidence of that, of the potential for inducing immune tolerance, whereby we can rid the transplant recipient from the requirement for lifelong immunosuppression. As I mentioned earlier, islet transplant in the eye can also be beneficial to insulin-dependent type 2 diabetics. And we published again, a couple of years ago, a report in another monkey that had type 2 diabetes demonstrating this proof of concept. So I will basically wrap up my slides by reminding you that this trial is active and recruiting. And again, anybody who is between the ages of 18 and 70 that has type 1 diabetes and is legally blind in one or both eyes can potentially qualify. If you know of anybody or you can please direct them to either call us at the DRI at this number, or they can locate the trial on clinicaltrials.gov and contact us through there. And again, that can be found either by searching for the specific study number or by Googling Abdulreda clinical trial. And of course, I'm always reachable via email directly or through the foundation team. So with this, I'll leave the slide on the screen, and I will be more than happy to answer any questions you have. And I would ask you if I answered all your questions that you asked me earlier. Did I?
Yes, yes, but I'll let other people go.
Thank you.
I have a question, Doctor. What is the purpose of having the restriction of being blind?
Well, because again, this is a very new procedure that has never been performed in humans. We opted for the conservative approach as to obviously mitigate any potential risk. And meanwhile, we are pursuing preclinical studies, as you saw, to be able to make a strong argument with the FDA at some point and then remove that requirement. So your question is really valid because we believe that this can potentially help patients, all patients, not only those with compromised vision.
Okay, right.
Doctor, I have a question. Going back to the slide where you showed that mice who were still, gaining weight and growing, still, the islets were still working, even though they were getting bigger. Does that signify that in the future, if this procedure was ever to be done on children, that if those children were still growing, that they wouldn't, that they would still be doing well years later as they grow?
That is a good way of putting it. Yes, that's certainly the natural conclusion from those data. But obviously, we cannot say 100% when it comes to humans until we have done it. But yes, you are certainly correct in making that conclusion. And another thing that I didn't speak about is the possibility of infusing additional islets, particularly after the induction of immune tolerance. So, as I mentioned, one of the great advantages of transplanting islets in the eye is the potential and the possibility for educating effectively the immune system of the recipient to be friendly towards the transplanted islets. And this immune tolerance state would open the door for additional islets to be transplanted elsewhere in the body, not necessarily in the eye, without the risk or with significantly less risk for immune rejection. So hypothetically speaking, in younger children who may receive the transplant at an early age, and as they grow in life, and the mass in their eye becomes, for some reason, less than adequate to provide full insulin independence, there is the possibility for infusing additional islets.
Doctor, do you think the islet transplants will be as effectively as long as the ones that have been done with liver transplants?
We think, in fact, that the eye will prove to be superior to the liver, okay, simply because of it's a very hospitable milieu or site for pancreatic islets. It is richly oxygenated, and there is minimal inflammation, if any, simply because of the immune privilege of the eye. So we think the eye will afford the islet graft longer longevity in comparison to the liver, which is a highly inflammatory organ. A lot of drugs, most drugs, if not all, get processed and metabolized in the liver. Many immunosuppressive, if not most immunosuppressive drugs also get metabolized in the liver. And there are toxin byproducts of those drugs when they get metabolized that are significantly very harmful to the islet graft there. So we think in the eye, the longevity of the graft will prove to be better.
Good.
Dr. Abdulreda, correct me if I'm mistaken, but the concept for this research, didn't this living window idea of being able to, did it come about because originally not for necessarily for the purpose of having a way of curing diabetes with the transplant in the eye, but simply for observation purposes, and then these great responses were observed? And am I going down the right path here?
Yeah, no, absolutely, Brandon, and thank you for bringing this up. For sake of time, I don't want to spend too much time on that background piece, but it is certainly the case. Transplanting islets in the anterior chamber of the eye was initially introduced by Professor Berggren, who is the director of the Diabetes Institute in Karolinska in Stockholm, Sweden, and has been a visiting professor at the DRI since 2001, to essentially do just that as a research tool, as a powerful research tool, to investigate the physiology of pancreatic islets in a living, breathing animal. It obviously, it is clear that we have learned tremendously about various cells in the body by studying them in a culture dish. But there is so much we can do and recreate relative to the environment, natural environment in the body in a culture dish. And when it comes to diseases like diabetes, which are chronic progressive diseases, this can never be modeled in a culture dish, let alone when you have a disease that involves multiple systems and organs, from the pancreas or the pancreatic islets to the immune system. The immune system requires the vascular system to access the islets and harm them. And then there is great evidence indicating involvement of the nervous system. So all these systems could never be created in the culture, in a culture dish. So that's why the idea was conceived to transplant islets in the eye to circumvent or to address all these technical limitations of what we call in vitro studies in a culture dish. And as I joined the DRI in 2007, I actually was introduced, and I'm grateful to Professor Berggren to have introduced me to this approach. And I started to use it to interrogate immune responses against islets in the context of diabetes and after pancreatic islet transplantation. And so the work I showed you, I had the privilege to start that, having been introduced to this very powerful research tool. And our work has matured and grown throughout the years to the point where we're in a place where we're evaluating this in a pilot clinical trial.
Doctor, did you say that even despite the transplant of the islet cells into the anterior chamber, the monkey still needed some insulin externally?
In that one monkey that I showed you, yes, it did, but its insulin requirements were reduced significantly. That particular monkey, however, received a relatively small islet mass, and by design, and despite that small islet mass, it showed significant improvement in its blood sugar control. But yes, you're correct.
So you're saying that theoretically you could put enough islet cells in the anterior chamber to remove the need for insulin, theoretically, possibly.
That is correct. In fact, we published a paper making this very case. I'll be more than happy to share it if you would like. It's a short but interesting read. We did in that study perform a relatively simple calculation, which is as follows. In the human pancreas, it is estimated that there are about 1 million pancreatic islets scattered throughout this organ that we know as the pancreas. Again, I mentioned that the pancreatic islets, which are scattered throughout the pancreas, collectively constitute what we call the endocrine pancreas. And these islets collectively constitute at most 2% of the organ. So those islets effectively constitute an overcapacity of insulin-producing cells. And we know this because when type 1 diabetes starts, it starts, years before diagnosis. And these insulin-producing cells undergo cell death and destruction progressively and chronically over a period of time that can vary from a few years to several years. And not only until more than 90% or so of them have been destroyed or gone when clinical symptoms appear. So we know only about 10% of that 1 million or so is needed to maintain normal blood sugar levels. We think we can put in the eye that equivalent of 10%. That's why we think we can remove the need for insulin through intraocular islet transplant.
Yeah, I have a question.
Yes.
Doctor. Yeah, I just want to understand the autoimmune response that actually kills the cells, the insulin producing cells. Why can't that autoimmune response can be treated to prevent the destruction of the cells when the diabetes starts?
This is an excellent question, Salim, but it is a very difficult one to address for various reasons. One is, as I mentioned, the disease, the autoimmune process can start very early in life. And there are indications that in some cases it may start in utero. And unfortunately, by the time this process starts, it's already difficult to undo it. And assuming that we know when it started, which is another very difficult thing to determine to begin with, how do we know when the autoimmune process starts so we can introduce some intervention early on before additional destruction of the insulin-producing cell happens? So the complexity of addressing this is embedded in the fact that we don't know when the process starts. And even if we did, it has been rather very difficult to figure out ways how to prevent it. We have been able to come up with different ways in animal models to prevent it, but when it comes to translating this to the human setting, these interventions have fallen short. Not until very recently, with the FDA approval of teplizumab, that still holds some promise. But if you paid attention to the press release, teplizumab was approved by FDA only in very few select stage 2 or 3 type 1 patients who basically are symptomatic and new onset patients. So this prevention idea, while it is the holy grail that we all look forward to arriving to or reaching, it is unfortunately a very difficult area. Resetting the immune system back from an autoimmune state has proven difficult for the various reasons that I mentioned, and more. I hope that
Yes, that
answers your
my
question.
question. Thank you very much. I just, if you don't mind, I ask another question.
Absolutely.
So the stem cells that are there from birth, right, for the person's stem cells, that I have studied a lot about that in terms of why can they be activated to actually create a rebirth of these islet cells that have been destroyed by the autoimmune.
Mm-hmm.
Is that something that you can look into, or somebody's looking into that? The original stem cells that were part of the pancreas itself or the islet cells.
Yeah.
I don't know what scientifically that means, but can they be activated to actually start producing insulin or rebuild the islet cells that have been destroyed?
Yeah, again, excellent question, and area of very recent attention. The stem cells and the stem cell, what we call stem cell derived islets or insulin producing cells. Right. As you know, there are a lot of researchers working on that. It is not an area that I'm personally involved in, but I am personally very interested in stem cell derived islets for transplantation purposes, because these stem cell derived islets definitely will allow us to address the major problem of shortage of organ donors and of organs for transplantation. any type of transplantation. You may know very well that thousands upon thousands of patients are waiting on waiting lists for a variety of organ transplants, from kidney to liver to heart to pancreas, and so this is a major problem. So stem cells can theoretically help us address that, because we can coax these stem cells to differentiate, to transform into the type of cell that we need, be it the insulin producing cell or whole islet cells, that is basically insulin and other hormone producing islet cells, pancreatic islet cells. But the issue of making stem cells, whether those that are within the pancreas, which is an area I have a little bit of knowledge in, and I can tell you it is not clear what cells within the pancreas are considered stem cells that have the potential to become something else. But assuming we know what those cells are, there is a lot of people working on identifying these. Some pancreatic cells called the ductal cells, which are part of the pancreatic duct, basically the canal that allows the juices to be secreted into the gut, are considered stem cells and have the potential to transform into insulin producing cells. Other people, including at the DRI, are working on what we call transdifferentiation of exocrine cells, meaning taking cells that are originally made to produce enzymes that help with the digestion as part of the exocrine pancreas, to transform, to transdifferentiate, to transform to basically another form of insulin producing cell, all for the very purpose that you mentioned, to repopulate, to regenerate the missed immune insulin producing cells, the lost immune cells during the autoimmune process. But there's a big but here, or caveat in this work. The risk of autoimmunity that caused diabetes in the first place will always be there. And even if we manage to produce cells from stem cell, insulin producing cells from stem cells or other cell types by transdifferentiation, we still have that risk. So we still need to figure out ways how to prevent the immune system from attacking these newly formed cells. That's why I'm very excited about our work on the transplant tolerance, because if we can educate the immune system of the recipient to be more tolerant, friendly towards these islets or these stem cell derived islets that we transplant, then that risk will be mitigated.
Great. How far you are in your research in trying to get there?
So that's a very good question. I think we have made good progress in our research. We brought this work from, the early stages of mouse transplantation in mice to a current state where we have an active recruiting clinical trial that is basically looking for patients who would qualify, that will fit these three main criteria you see on your screen. And hopefully they will qualify. We will screen them and they will qualify. So I think we have made progress, but obviously the work continues. And so we're looking forward to transplanting patients under this trial, and hopefully everything continues to prove safe and effective, so we can advance this further to seeing patients, not only blind ones, and beyond.
Okay. My last question before I'm taking too much time. I'm sorry about that. But,
it's okay.
Question comes to mind is, I have type 1 diabetes for more than 40 years. I was diagnosed when I was 19 years old. But the diabetes is under control, thanks God. is this qualifies for this trial if I need to be part of this trial?
If you're controlling your diabetes well, which I congratulate you on, you may not qualify because, and again, I hope your eyesight is also good since you're controlling your diabetes good. I hope that is the case.
Yes.
Then you won't.
Okay.
But we're always open to screening. We have a screening tool that we can screen you by phone. You answer a few questions, and basically based on that, we'll determine if you initially qualify. If so, we'll do another layer of deeper screening, and ultimately we'll bring the patient in to UM, to DRI, and to Bascom Palmer to undergo a thorough in-person evaluation before the patient is listed in the trial. But it sounds like for yourself, God bless your heart, you don't qualify.
Oh, I see. Okay. All right. I'm looking forward to the further research and always hoping that this will happen one day. The treatment will come up.
Thank you.
And it looks like we have gone over our hour, and I want to be mindful of everyone's time. So maybe if we have one final question and we can wrap it up. Okay. Well, if there are no more questions, I just want to say thank you to Dr. Abdulreda, and thank you to everyone who participated in this